Hi friends, welcome to the channel. It's a routine case and we planned stop and chop Phaco, grade 2 nuclear sclerosis. I always pour visco over the cornea to make the clarity more. Now it's time to make a posterior limbal incision. We are planning to make a 3 planar incision. You can see some blood is oozing out from the section. That's good for the faster healing. Our tunnel length is at least 1.5 mm. I try to make. You can make up to 2 mm also. Less than 1 mm there are chances of the leakage of the wound. Staining is done. Phenocaine injection done for better dilatation. As the case was in topical, it also gives some anesthesia. Now it's time to do capsular access. I prefer to use a 26 gauge needle for capsulotomy. You can use a rhexis forceps also, whatever you are comfortable with. Our aim is to get at least 5 mm of capsular access. As you can see, it's grade 2 cataract. So this much of capsular access is sufficient. Making a side port, also called the lens tip, 15 degree. 4 clock hours away from the main incision. If you make the side port incision nearer to the main incision, less than 3 clock hours away, then there are difficulty in manipulation or breaking the nucleus. Now we are doing the hydro dissection. As you can see, while doing the hydro dissection, our one edge of the nucleus came above the back. We pushed it back into the bag also. Now it's time to start the Phaco. I have zoomed it for better visibility. Entering into the eye with Phaco 1. Vacuum is 80, power is 60 and flow rate is 25. You don't need too much of vacuum in Phaco 1. Clearing the epinucleus and cortex to make endonucleus visible. It's a very helpful step. Any air bubble coming into the AC should be cleared first to make the clarity. Now we are making a trench. In starting cases, you can make trench one side, then rotate the nucleus, complete trench. Or with your experience, you can make the trench in single go also. The trench depth is at least 80 to 90% of the nuclear thickness. It's more deeper in the center as the nucleus is thicker in the center compared to periphery. Now it's time to break. We have come to the slow motion. You can see we got the break. As we are breaking the nucleus into 2D segments, you can see there is a small attachment there which I missed and thought the breakage is complete. And you will now see how this small attachment will trouble me further in the case. Now we are shifting to Phaco 2 with vacuum 400, power 60 and flow rate of 40. As I am taking one of the D segment, I did the vertical chop and trying to lift the nuclear piece to aspirate and emulsify. You can see as I am pulling the nuclear piece towards the center, with that attached other D segment of the nucleus is also coming out of the back. And there is a small attachment between this smaller piece and the bigger D segment. So I decided to pull out my Phaco probe and inspect the attachment. As you can see, small attachment is there with the help of the dialer. I pushed back the bigger D segment nucleus in the back. Should never have such a bigger segment into the AC while doing the Phaco because it can damage the endothelium and there are high chances of the PC rent. Only smaller pieces of the nucleus should be brought out from the bag after chopping and emulsified and aspirated. Now we are proceeding emulsifying the small piece and aspirated. Now the other part, vertical chop is done towards the center, emulsified and aspirated. So this is a very important step. You should take care that the break should be complete and full depth, and only the smaller pieces of the nucleus should be brought towards the center and above the bag at the iris plane. That is the best place to emulsify and aspirate the nuclear pieces. If you have to deposit the nucleus back into the bag, you can use the visco, and with the help of the dialer you can push it back, and also you can take the help of your Phaco probe to push it back if you have experience doing so many cases. Now we are in Phaco 3 epinuclear mode, where the vacuum is hardly 250, power is 40 and flow rate is 25. Pushing visco inside the eye. It's time to do the epinuclear and cortical wash using a coaxial IA at a vacuum of 400 and flow rate of 40. As you can see, there is a thick epinucleus in the bag with cortex. So I am trying to pull the epinucleus towards the center from all the sides. A big chunk of epinucleus and cortex is aspirated. Now some inferior nasal quadrant cortex and epinucleus there. Now as you can see, I am going below the epinucleus and separating it from the posterior capsule. At this step you have to take care that your coaxial IA hole should be upwards. This way you delineate the cortex epinucleus from the back and can aspirate it. Cortical wash is completed. Now it's time to put the lens. Here I am using Hoya Impress lens. It is an advanced monofocal lens. Comes in a multi-set injector. You can put it both by screwing or pushing the injector. The lens is in the bag now. Now it's time to do the visco wash, going with the coaxial IA. Removing the visco above the lens and from the angles. Now going behind the lens, my favorite step, lifting the edge of the lens and at lower vacuum, aspirating the visco behind the lens. Visco wash should be given time and we should be done properly. Now it's time to hydrate the wound. As you can see, a small AC wash with the BSS hydrating the main wound both sides. Now finally hydrating through the side port. May it will help you. Thanks for watching. Any comments, please write in the comment box.